ml of fluid, which is a lot. A chest X-ray PA erect view will need somewhere close to 200 to 250 ml fluid. A lateral radiograph is much more sensitive. It will detect around 75 to 100 ml fluid, whereas ipsilateral lateral decubitus can detect close to 25 to 50 ml. So you don't really have to memorize these values. There's always a range, and these figures are also given slightly variably in different sources. But as a range, you want to remember ultrasound followed by lateral decubitus, followed by lateral, chest X-ray erect, and so on. This is the order of sensitivity for fluid. Now, what I'm going to teach you here is very, very important. This is an approach to opaque hemithorax. Whenever you have one side lung which is completely white, there are three main possibilities. You will have to look at the mediastinal shift in order to distinguish. So look at the first image. You can see that this right side is completely white. And how is the mediastinum? You can see it is being pushed. There is contralateral mediastinal shift. In this case, the biggest possibility you want to keep in mind is a massive pleural effusion. So when you have massive pleural effusion, the entire lung is going to be opaque and you see a contralateral shift. Look at the second image. The second image, you can see the left side lung is opaque and you can see that the mediastinum, the trachea, is being pulled on the same side. So when you have ipsilateral mediastinal shift, it is either collapse. What is the meaning of collapse? It means that now, because of some obstruction, maybe this is a mass, there is a bronchogenic cancer occupying the main left bronchus. So what's going to happen? Complete lung is collapse, total obstruction. In that case, why is the lung white? Because the air of the alveoli is gone. So it appears white, but because there is volume loss, there is ipsilateral mediastinal shift. So one possibility is collapse. The other possibility is pneumonectomy. Maybe the patient underwent surgery. Yeah, so in that case, you will have history. So this is the second possibility. And the third possibility is where there is no shift. This is where you see opacity. Now, very rarely will it be a complete hemithorax. It will usually be a lobe. So this is what is a consolidation. So consolidation is an opacity where alveoli are filled with pus, right? So pneumonia is a consolidation. The alveoli are filled with pus. In that case, you'll have one lobe, lobar consolidation, and there is no mediastinal shift. So opaque hemithorax, pushing mediastinum is pleural effusion. Pulling mediastinum is collapse or pneumonectomy. No mediastinal shift is consolidation. Very, very useful approach. Now look at the other image. Very, very important. So now when we look at this X-ray, first of all, just a bird's eye view, you don't really see any opacity. So now look for the side which is more blacker. When you don't see anything white, now look, is there something extra black? There is. On the right side, now can you appreciate that there is a hyperlucent lung field? So when you see this hyperlucency, extra blackness, this is pneumothorax. This is where now the pleural space is filled with air. That's not why. Can we see it as more black? Because lungs also have air. Why is this extra black? The lungs are black because they're filled with air, but they also have these bronchovascular markings. This appears extra black because this is in the pleura where there are no bronchovascular markings. So this is what appears hyperlucent, meaning extra black, because there are no bronchovascular markings. Did you understand this? So hyperlucency without markings is pneumothorax. What will be the mediastinal shift? Again, it will push the mediastinum to the opposite side, contralateral shift. Most sensitive investigation. So anytime you want to see air, just like anytime you want to see fluid, it's going to be ultrasound. Anytime you want to see air, it is going to be a CT. So CT is the most sensitive investigation here. The most sensitive X-ray, remember, for a pneumothorax is an expiratory chest X-ray. What does this mean? So normally when I take chest X-ray, it's always an inspiratory view that we have to take, alright? It's always end inspiration. If you've ever seen somebody getting an X-ray or get it done yourself, we say that take a deep breath and then hold your breath, yeah? In Hindi, we say lamba sa andar lo or rok lo. Means we're going to take an end inspiratory view. Now, why do we do that? We do that because I want more air in the lungs. Here, I want a differentiation between pneumothorax air and lung air, isn't it? So here, don't you agree that if I make my lungs whiter, this gradation becomes even better? So how can I do that? I can do that by taking an expiratory radiograph. In an expiratory radiograph, the lungs themselves are going to become whiter, hence highlighting the blackness of pneumothorax, because pneumothorax is not going to change in an expiratory radiograph. That's going to remain as it is. So that's why expiratory chest X-ray can pick up pneumothorax. Getting it? Now, let's talk in terms of trauma. Now, what I'm teaching you is the basis of trauma pneumothorax. You have a patient who undergone chest trauma, has pneumothorax, they will ask you what to do next. If the patient is in shock, unstable patient, this is what I call as tension pneumothorax. This shock is actually an obstructive shock because the outflow vessels of the heart are compressed by the mass effect. So this tension pneumothorax, remember, is a clinical diagnosis. It's not a radiological diagnosis. That's the first learning point. What do you do next? So when your patient is unstable, what you have to do is put in a needle. So needle thoracotomy is what you are going to do next. You're going to put a wide bore needle in the 5th intercostal space, mid-axillary line in an adult, and a 2nd intercostal space, mid-clavicular line in a child. Okay, so this is where you're going to put your needle. So don't just stop there. You're going to then go ahead and put an intercostal drainage tube. Intercostal drainage tube is put in the 5th intercostal space in the triangle of safety. Yeah, while I've talked about it, we've also seen this in BTR, but triangle of safety is going to be the 5th intercostal space below. You know how we used to study lady between two majors? So remember lady and one major, latissimus dorsi posteriorly, P major anteriorly. That's the triangle of safety. While I'm going into it, 5th intercostal space, imagine this is the 5th intercostal space. If I ask you which point will you put your ICD, A, B or C, but it doesn't matter. You have to remember the concept that the intercostal vessels and nerves run along the inferior border of a rib. So I will never go along the inferior border of a rib. I will go along the superior border of the inferior rib. So it's the point C where you're going to put. Don't memorize the line. Understand this image and you will never forget it. So vessels run below the inferior border of the rib. So I always have to go along the superior margin of the inferior rib, right? But if the patient is stable, all I have to do is put an ICD directly. So this is the management of pneumothorax. Next, we're going to learn about E-fast. Remember how we said E-fast is done in trauma. Extended fast can be used in thorax to evaluate pneumo and hemothorax. Now, I also said that air is the enemy of ultrasound. Yeah. So then, ma'am, how can you detect pneumothorax? That is because I am not actually trying to see the air. We have the two layers of the pleura. They are sliding one over the other. So this is the parietal pleura, this is the visceral pleura. They are sliding. So I am actually trying to see that motion. If there is pneumothorax, the sliding stops. So that's why I use this special mode of ultrasound called as M mode ultrasound, M for motion. Look at this. When we see that there are these lines, and then there is this granularity. This is what we call as the seashore sign. These are the waves of the ocean and this is the beach. When do you go to a seashore? When do you go to Goa? Do you go during exam time or do you go during normal times? After exam, we go during normal times. That's the correct answer. So seashore sign is seen in normal. That's how you remember. But look at this image. No beach whatsoever. All I see are just lines. So what is this? This is what has been called as barcode sign, also called as stratosphere sign. So this barcode or stratosphere sign is what we see in pneumothorax. So seashore sign, normal lung, barcode or stratosphere seen in pneumothorax. Right? So that's how we can detect pneumothorax on ultrasound using the M mode ultrasound. Now I'm going to show you a few X-rays which are confusing again, and all of these have one horizontal level that you can appreciate. So let's understand the difference. First of all, I want you to look at the second image here. We studied hydrothorax, we studied pneumothorax. What if there is both? In that case, the entire pleural space is now going to have what? It's going to have this level. So this is the fluid, this is the air fluid level. So horizontal air fluid level in the pleural space is hydropneumothorax. We're going to put an ICD next. So this is sorted. Now another air fluid level, but now it's a rounded lesion in the lung which has an air fluid level. So this is actually an abscess. Abscess has pus which settles and air which is above. So this is a lung abscess, right? Look at the third image. Is this hydropneumothorax? It can't be hydropneumothorax. This is below the diaphragm. So what is this? Is this even abnormal? No, this is nothing but the stomach. Our stomach normally has air. We have seen that. But then why is the stomach in the thorax? The stomach is in the thorax because of a diaphragm injury. So in context of trauma, this image represents a diaphragm injury where the stomach has been pushed into the thorax. So here the diagnosis becomes diaphragm injury. This has been asked very smartly once they gave this image and they asked, what is it that is contraindicated in this patient? And ICD was the answer. Will you ever put an ICD? Few of you might have thought that, oh, this is hydropneumothorax, this is air fluid level, you go ahead and put an ICD. Patient already has a diaphragm injury, now you've just created a stomach perforation. Never do that. So this is where you have to recognize that it's stomach, it's below the diaphragm, it has been pushed up into the thorax because of diaphragm injury, right? Now look at this. Where is the air fluid level? It is behind the heart. So whenever we see a retrocardiac air fluid level, this actually represents the herniation of stomach into the midline. How does that happen? So this is a hiatal hernia. This is the herniation of the stomach via the esophageal hiatus. Which type of hiatal hernia? So you know there are two types. There's sliding hiatal hernia where only the GE junction comes up, and then there is the rolling type of hiatal hernia where GE junction stays put and the rest of the stomach comes up. Which one do you think this is? So when I see this air fluid level into the thorax, this can't be sliding because there only GE junction is coming. I can see the entire fundus up here, isn't it? So this one is the rolling type of hiatal hernia, right? So these are the four air fluid levels we need to know. If it's a lung lesion, it's an abscess. If it's the pleura, it's hydropneumothorax. If it's stomach coming up into the thorax, that's diaphragm injury. And when it's in the midline, that's a hiatal hernia. Right? This is where I've seen most of the students getting confused. Moving on now to consolidation. So whenever you see an opacity, right, an ill-defined confluent sort of an opacity, that is what we call as a consolidation. Here you frequently get asked, where is this consolidation located? So now right upper lobe is pretty clear, it will be up there. But middle and lower lobe, because X-ray is a two-dimensional investigation, tend to overlap. So that is where middle and lower can't be distinguished just on the basis of the location. So this is where we need to understand something that is called as the silhouette sign. What is the silhouette sign? So silhouette sign you need to understand is to learn the demarcation between two structures. So I'll explain further. You can see there is an opacity here. Can I know definitively the difference between this opacity and the hard border? I can't really. Both of them are merging into one another. So when you see that an opacity obliterates the hard border, we cannot distinguish the opacity from the hard border. It is in the middle lobe. So when it silhouettes the right hard border, it's the middle lobe, right middle lobe. If it silhouettes the left hard border, it is in the lingula. So we don't have a left middle lobe, so we call that as lingula. So did you understand? Silhouetting right hard border is right middle lobe. Silhouetting the left hard border is lingula. If something silhouettes the diaphragm, that is the right lower lobe or the left lower lobe. So if you see silhouetting of the diaphragm, that's lower lobe. If you see silhouetting of the hard border, it's middle lobe. That's how we use the silhouette sign. So just to make sure you've understood, now look at this X-ray here. Can you tell me this opacity is middle lobe / lingula or lower lobe? So it's on the left side. So either it's lingula or left lower lobe. What do I see? Can you appreciate here that the hard border can clearly be distinguished from this opacity, and it is silhouetting the diaphragm. I can't really see the diaphragm contour. So where is this located? Very nice. This is in the left lower lobe. Did you understand? So now see first and third X-ray together. Middle lobe, silhouetting hard border. Distinct hard border, lower lobe. Right? So that is how we apply the silhouette sign. Another way to distinguish is to see a lateral view. They give you lateral radiograph. Look here. If an opacity, can you see this is the opacity here? If an opacity overlies the heart, this is the middle lobe. This is how the fissures are oriented, right? So this is usually the horizontal fissure, and this is how you're going to have the oblique fissure. So this is the middle lobe. If you have an opacity occupying the lower lobe, this is the position it will be in. It will obliterate the spine. So that is what we call as the spine sign also. So if something overlies the spine, that's lower lobe. If something overlies the heart, that is middle lobe. So this is what is the silhouette sign for localization of a consolidation. In addition, look at the third X-ray now. We already see that there is a left lower lobe consolidation. You can also see that there is an air-containing lesion here. So there is an air-containing lesion here. This is what is called as a pneumatocele. So we have here a left lower lobe consolidation with a pneumatocele. A pneumatocele is a classical finding of a Staph aureus pneumonia, right? Most of the pneumonias, the lobar consolidations, are caused by pneumococcus, as pneumonia is the most common cause of lobar pneumonia. Pneumatocele is the hallmark of Staph aureus pneumonia, right? So that's what you want to see here. Further, going ahead into HRCT. Do you remember when we began our discussion of rapid revision, we said that high resolution CT is the investigation of choice for any respiratory pathology. So for any infection that you want to see, we are going to look at HRCT. So that's what I'm going to show you. I'm going to show you lots of HRCTs. All of them are presenting to you with features of infection. We see the CT and we diagnose. So look at the first image. Bilaterally, you can see that there is complete opacification. We can't see the underlying lung at all. And you can see that the bronchus has air. So when you see this sort of an appearance, this is a classic consolidation, hallmark of a lobar pneumonia. So this is a consolidation, and the sign is what we call as the air bronchogram sign. It represents that the alveoli are filled with pus, but the bronchus is normal, right? So the bronchus leading up to it is filled with air, but the alveoli being filled with pus or fluid are going to be opaque. So this is consolidation with air bronchogram signs. Repeat, neat question. Looking at the second image, you can see that this is where a bronchus is having these nodules. You can see that along the bronchus there are these nodules, and this is what we call as a tree in bud appearance. It looks as if there is budding along a tree. So this tree in bud carries the answer in the name itself. So this is what you see in active tuberculosis. It represents TB, which is present within the bronchus. So this is what represents active TB, endobronchial spread of TB, and this pattern, you may hear one more name that is called as centrilobular nodules. So just remember, this is TB, which is active, it's within the bronchus. Tree in bud is endobronchial spread of tuberculosis. Look at the next image. Again, patient with chronic recurrent cough. What do we see? Now, normally, when you see these white lines on the HRCT, they are the bronchovascular bundle, as we said. Normally, the artery and the bronchus, both of them are the same size. Yeah, both of them have the same size. But when there is bronchiectasis, now the air-filled bronchus will enlarge, artery remains as it is. So this is what gives rise to the signet ring appearance, and that indicates that the bronchial tree is dilated, called as bronchiectasis. So bronchiectasis, remember, is the irreversible dilatation of the bronchi. Look at this image. This is the artery. This is the thickened bronchus. So this image is bronchiectasis. Yeah. So for all of these, remember, anything pulmonary investigation of choice is always HRCT that we have seen. Look at the next image. This is where they will tell you that this patient is immunocompromised. So either they will give you a person who's having HIV/AIDS, or they will give you this person is on chemotherapy. They use a term called as febrile neutropenia. So a neutropenic patient who has fever, and you see the CT where you can see that there's a solid nodule with surrounding ground glass opacity. So look at this. Center is solid with a peripheral GGO. What is GGO? Ground glass opacity is when you see an opacity in the lung, but it is not as white as consolidation. Can you appreciate this? This is consolidation, completely white. Can't see the underlying lung. But if you can see little underlying lung, that is ground glass opacity. Can you understand this? So this actually, have you seen these glasses where you can see that somebody's inside, but you can't exactly see what's going on? That's ground glass. So when you see this solid center with peripheral halo of ground glass opacity, this sign is referred to as halo sign. So these multiple solid nodules surrounding GGO, this is diagnostic of invasive aspergillosis, particularly in the context of this immunocompromised patient. Very, very important. You have angio invasion leading to bleeding, and it's this bleeding actually which gives rise to the ground glass opacity halo. Fine. So this is aspergillosis. Don't confuse it with an aspergilloma. This mistake also I've seen a lot of students do, is to confuse aspergilloma and aspergillosis. Aspergilloma is a fungal ball. You'll have a cavity. Usually cavity comes from TB sequelae. Within the cavity you have a fungal ball. It is not an invasion. It is a saprophytic infection. So this is a fungal ball within the cavity. That is what is called as an aspergilloma. Fine. So this is what we need to remember. They are not the same. Aspergilloma will affect patients with TB cavities, not immunocompromised patients. All right. On the other hand, look at this image now. Here you can see the opposite. You can see a reverse halo, isn't it? So reverse halo sign is where the periphery is solid and the center is where you see the ground glass opacity. So this is reverse halo. Two context we can see this. One, if you see again an immunocompromised sick patient, this reverse halo sign can be seen in mucormycosis, pulmonary mucormycosis. But if you have a patient who's not sick at all, in context of an interstitial lung disease, another DD, ILD is actually an organizing pneumonia, OP. This was previously called as cryptogenic organizing pneumonia, COP. Now we call it organizing pneumonia. So two cases of two DDs of reverse halo sign, mucormycosis versus organizing pneumonia. Right? So we've done halo, we've done reverse halo. So now look at this HRCT here. Is this consolidation or is this ground glass opacity? So here, can we see the underlying lung? That's the point I want you all to understand. So this is where you can actually see the underlying lung. It's not as white as consolidation. So this is what we call as GGO. I'm sure during the pandemic, all of you have seen these multiple reports of HRCTs saying GGO, right? So ground glass opacity, when you see these multifocal, so when I see these multifocal peripheral ground glass opacities, this is what is the hallmark of COVID-19. So COVID-19, the hallmark is multifocal peripheral GGOs. This is what we call as typical COVID-19. We used to give a score of COVID-19, which is CORAS. Typical COVID is CORAS 5, right? So that's what you need to remember. A normal HRCT is CORAS 1. 2 is where it is a benign finding. 3 and 4 are equivocal. 5 is typical COVID-19. 6 is where the patient is RT-PCR positive. Just remember, typical finding, multifocal peripheral GGOs. Look at the next HRCT. We can see that there are multiple small millet-shaped nodules. This is what we call as the Meyery nodules. So Meyery nodules, remember, the first possibility in case of fever, infective symptoms is always always tuberculosis. But there are various DDs to it. What are the other causes of miliary nodules? Once this was asked that a patient has miliary nodules and there is eosinophilia. In that case, you have to think of Loeffler's syndrome. Loeffler syndrome, also called as tropical pulmonary eosinophilia, in which case, you're going to have eosinophils with miliary nodules. So that's another DD. Then in varicella, healed varicella particularly may give rise to these miliary nodules. You can also see miliary nodules in histoplasmosis, which is a very close mimic of tuberculosis, right? So these are the various DDs you want to remember about miliary nodules. Look at this patient now. This is an interstitial lung disease. They'll give you spirometry findings, they'll give you rails, okay, so spirometry showing restrictive lung disease, and then what you are seeing here on the HRCT, can you appreciate these black things? This is what looks like a honeycomb. There are various cysts which are stacked one on top of the other. So this finding is what is called as honeycombing. So when you see this honeycombing, in addition, you can see that the bronchus leading up to it is dilated. That is what we call as traction. It's the fibrosis which is pulling the bronchi and making it dilated. This is what is traction bronchiectasis. And what you see is a lower lobe predominance, basal, lower lobe predominance. When you see this triad, this is what is the hallmark of UIP or IPF. UIP is what is the clinical radiological diagnosis, usual interstitial pneumonitis. Pathological counterpart of the same, both are synonymous, is IPF, meaning idiopathic pulmonary fibrosis. So just remember the short forms, UIP or IPF. The hallmark is honeycombing, right? Going on to the last HRCT that we need to know. So here we have a patient who is HIV positive with a CD4 below 200. Always keep an eye out for CD4 below 200. And then when you see this bilaterally diffuse involvement, so you can see this bilateral ground glass opacity. Sometimes there will be cysts also that can develop. Lung cysts will be air-containing black lesions. So bilateral GGO cysts. This is the hallmark of PCP pneumonia. PCP pneumonia tends to affect HIV patients, CD4 less than 200. So that's why we have to give prophylaxis as well as treatment. Both of these are done with cotrimoxazole. So this is what is very, very important. Let's rule out. Can this be TB? No, neither is this train bird nor is this miliary pattern. Pneumococcus is going to be a lobar consolidation, not bilateral GGOs. Aspergillosis we saw were halos. They were nodules with a halo sign. So this indeed is PCP, right? Next, I want to talk to you about edema, pulmonary edema. So when I say pulmonary edema, it can either be cardiogenic pulmonary edema, means it is developing because of left ventricular failure, or it could be non-cardiogenic pulmonary edema, which we also call as ARDS, acute respiratory distress syndrome, which could happen because of any other systemic cause, right? So we need to first distinguish the two. Let's talk about cardiogenic pulmonary edema first. What happens when the left ventricle fails? The blood overloads in the left atrium. From the left atrium, it goes back into the pulmonary veins. So essentially, the pulmonary venous pressure increases, the pulmonary veins begin dilating. So the earliest change that I see is cephalization. The pulmonary veins of the upper lobes become dilated as compared to lower lobes. As this pressure further increases, what happens is the peripheral pulmonary veins begin to get dilated. Those are present within what we call as interlobular septa. So this interlobular septa becomes thickened. These interlobular septal thickening on an X-ray looks like these horizontal lines. Can you see these horizontal lines? They are what we call as curly lines. Curly lines are most commonly appreciated at the base of the lung. Can you see this is the CP angle? So at the base, when we see these horizontal lines, these are the curly B lines, okay? So these are curly B lines. Curly A lines can be seen near the hilum, they are the oblique lines. So not important, but just remember these lines are more commonly seen at the base. So this is the second stage. After cephalization, we see this curly lines. As the pressure further increases, now the fluid from the pulmonary veins goes into the alveoli and you start to have consolidations, and though they are going to be central, this is what we call as bat-wing consolidation, or perihilar consolidation. So these are the findings of cardiogenic pulmonary edema: cephalization, curly lines, perihilar consolidation. Can there be associated pleural effusion? Yes, we can have transudative pleural effusion. Versus ARDS. ARDS is going to have multifocal peripheral consolidations. That is where you have this patchy appearance, no central predisposition. Will I ever have curly lines in ARDS? No, there is nothing to do with pulmonary veins. There will be no curly lines. There will be no pleural effusion. So that is what is very, very important. ARDS versus cardiogenic. If you understand the pathophysiology and the concept here, you will not need to memorize it. Okay, so this is pulmonary edema. Going on into two places where you're going to hear the popcorn sign. So one, this is a mammography. Within the mammography, if you see a well-defined and describe it as a breast mouse, and you see this popcorn calcification, this is what is pathognomic of a fibroadenoma. It's a benign breast lesion. On the other hand, if you see a popcorn calcification within a pulmonary nodule, this is what is a hematoma. A pulmonary hematoma, also called as a chondroma. Chondro meaning cartilage, is the cartilage which makes it white, the calcification. So hematoma or chondroma, this is the most common benign tumor of the lung. So this is what you need to know about popcorn calcification, right? One more case, very, very important. So here you have a patient who comes to you with dysphagia. What can you see? This is the barium swallow. Can you appreciate that there is a posterior indentation of the barium column? How do I know posterior? Can you see the vertebra here? So this is a posterior indentation on the barium swallow. So that is the barium swallow finding. You do the CT and see what we find. We find that this is the arch of aorta. Normally, arch has three main vessels. What are the three vessels of the arch? From right to left, we have three arteries: brachiocephalic artery, which further divides into right common carotid and right subclavian. We have the left common carotid and the left subclavian. You can remember as Budd-Chiari syndrome. This is an anomaly where you have aberrant right subclavian artery, ARSA. What is aberrant right subclavian artery? Here there is a fourth branch. You have right common carotid, left common carotid, and left subclavian, and right subclavian arises as the fourth branch from the arch. Can you see this? And this branch courses behind the esophagus. So look here, this air-containing structure is the trachea. Behind that is the collapsed esophagus. We have this vessel pulsating behind the esophagus and then going on to the right side to form the right subclavian artery. So this is why, because of the pulsation, this patient will have posterior indentation leading to dysphagia. So a vascular issue leading to a GI presentation. Very unique, very important. So this is what we call, this presentation is what we call as dysphagia lusoria. And you want to remember the cause as ARSA. It stands for aberrant right subclavian artery. Right? Very important. Looking at the questions here, so we have a male presenting to trauma center with shortness of breath, supine X-rays shown. So on supine, you will not see the meniscus, you will see complete opacification. So what is it? Complete opacification on contralateral shift, hemothorax. Can this be pneumothorax? Never, it will have air. Can this be diaphragm injury? No, that will have raised hemidiaphragm. What is a contusion? A contusion is like a consolidation, okay? It's a parenchymal injury to the lung. That will have one, just like consolidation will affect one lobe, it won't be diffuse, it will not have mediastinal shift. Okay, eggshell calcification is the hallmark of sarcoid and silicosis. This is where the lymph nodes have this peripheral rim of calcification. These are the two main details, but this may also be seen in post-radiotherapy. Any treatment, that you give to lymphoma, which is radiotherapy or chemotherapy, can develop this calcification, but this is not something you see in metastasis, okay? So that's the best option here. Which of the following is true regarding CORADS? CORADS 0 is not normal. It indicates incomplete or inadequate study, which needs repeating. CORADS 5 is typical. That is true. And what is the typical finding? We saw multifocal peripheral ground glass opacities. Is pleural thickening typical? No. Is lobar consolidation typical? No. So as a general guideline, remember, anything which is typical in TB is not typical in COVID. Yeah, so consolidation, thickening, all of these are not typical of COVID-19. 45-year-old male presents to trauma center. What we see is diaphragm injury. I already revealed this answer. What is contraindicated? This is diaphragm injury. This is not hydropneumothorax. We will not put an ICD. 6-year-old child presents with hypertension. Lower limb pulses feeble. Inferior rib notching. So inferior rib notching. What happens? This is coarctation of aorta. In coarctation of aorta, you have a narrowing here, just distal to the ductus arteriosus. So because of which the blood to the lower limb is compromised, and that's why there is a brachiofemoral delay. There is feeble femoral pulsation. These are your buzzwords for coarctation of aorta. So how do I send blood to my lower body? So here you have a collateral circulation. The intercostal arteries open up and they pulsate, sending the blood to the aorta. We already saw that the intercostal vessels are at the inferior rib border. They become so dilated that they are now going to pulsate really hard and lead to inferior rib notching. That is your finding of coarctation of aorta. Silhouette sign. So independently, first look at this and tell me, is it linear or is it lower lobe? Can you appreciate the heart border separately? We can't. So this is silhouetting the heart border. You can see diaphragm is seen separately. So this is left heart border silhouette sign positive, meaning it is in the linula and location can definitely be commented. So this is what is linula silhouette sign positive. Cattle handler, hemopsis, chest pain. What do you see? You see a cavity, and can you appreciate these membranes crumpled down? Remember what I told you when we were studying hydatid? This is the water lily sign in the lung representing a pulmonary hydatid cyst. A pulmonary hydatid cyst, remember, does not calcify. Yeah. Next, 35-year-old female with Raynaud's phenomenon, tightening of the skin, bilateral rales. So all of the connective tissue disorders, remember in this case we are likely talking about scleroderma, have a risk of interstitial lung disease. That is what you're expecting when you see these rales and crests. What is the investigation of choice for ILD? We have already seen as HRCT. Echo, PFT, MRI will not help. It's HRCT chest. 54-year-old male dyspnea, eosinophilia with miliary, not military, miliary modeling. What is it? Tropical pulmonary eosinophilia. Just that you don't have to be biased about TB. The moment you see miliary, don't mark TB. If it's eosinophilia, it's Loeffler syndrome or tropical pulmonary eosinophilia. So that is it for thoracic radiology. Next, we will move on to neuroradiology. So now beginning with neuroradiology. The first thing I want to discuss is the radiological anatomy. This is where you get questions, pointing at a structure and they'll ask you associated questions. So I'm starting with the most important level here, which is the level of the basal ganglia. Before I jump to the anatomy, the modality. What is this modality? Is this CT, MRI, ultrasound, X-ray? So you can see that the bone here is black and that means it's an MRI. We have already been through this for the brain, spinal cord, nerves. It's always MRI that we're going to prefer, right? So this is the MRI. And which sequence of MRI? So whenever you see that the water or the CSF is white, whether it's this image, or for that matter, this image, all of these are T2 weighted MRI. Okay, water is white, World War II. So first section, that's the level of the basal ganglia. These are the lateral ventricles. These are the frontal horns. These are the occipital horns. And what you see here in the center is the third ventricle. Yeah. So first of all, these are lateral ventricles and this is the third ventricle. On the two sides of the lateral ventricle, what is this nucleus that you can see here? So this is going to be the caudate nucleus. So what you see here on the two sides of the lateral ventricle is C for caudate nucleus, right? So that is the caudate nucleus. Then what you can see here as this lens-shaped nucleus is the lentiform nucleus. This lentiform nucleus, you can see the outer part is putamen, inner part is the globus pallidus. So putamen, globus pallidus is the lentiform. On the two sides of the third ventricle, what we have is the thalamus. So this is the thalamus, and you can see here, this is the internal capsule. This is the anterior limb, genu, and posterior limb. So this is the internal capsule right here. So this is what constitutes our basal ganglia. We'll keep adding on to this knowledge as we go along, but this is the bare minimum we need to know. As we go down, we have the brainstem. So if I ask you what part of the brainstem is this? Is it midbrain, pons, or medulla? What will you say? You'll say this is the pons. First of all, pons is the widest part of the brainstem, right? What you have to do to identify is anterior to it will be the only unpaired vessel of the brain. And that is which vessel? This is the basilar artery. So basilar artery is the only unpaired vessel and it runs in the prepontine system. So this makes it pons, and you can also see the fourth ventricle behind it. So that's how we identify. These are the two cerebellar hemispheres joined in the center by the cerebellar vermis, right? So this is what is the level of the pons. Just to correlate on a sagittal view again, just finishing brainstem off. So this part here is the midbrain. Then you can see the bulbous part is the pons. And can you appreciate the vessel anterior to it? Vessel doesn't appear as black on an MRI because the velocity of the moving blood is so fast that it cannot generate a signal. And that is what we call as a flow void, right? So we see the flow void of the pontine artery, or basically the basilar artery in the prepontine system, and you can see the fourth ventricle behind it. So that was the axial cut we had seen, and this thin part here is the medulla. So this is the fourth ventricle, this is the cerebellar hemisphere, and what has been marked is the cerebellar tonsil. Okay, so what has been marked here is the tonsil, cerebellar tonsil. Okay, apart from this, what you can also observe here, this is the corpus callosum, right? So this is the corpus callosum. Corpus callosum is made up of four parts. Anteriorly, we have rostrum, then we have genu, body, and splenium. RGBS, rostrum, genu, body, and splenium is the posterior part, which is important. Fine. You can also see here, this is the sella. The sella is just above the sphenoid sinus, and that is where the pituitary is housed. And just above the sella, so if this is the sella of the pituitary, this is where you have the optic chiasma. So OC is the optic chiasma. That's why big sellar lesion, big pituitary lesions can compress on the optic chiasma, leading to bitemporal hemianopia. Right. So this is about the relevant anatomy we need to know. Now jumping onto the most important topic, you usually get one question from this, and that is head trauma. So what you want to remember here, the investigation of choice for head trauma is NCCT. We've already been through this. Anytime I want to see acute hemorrhage, it's going to be hyper dense on the CT, it's going to be white, and that's why I do a non-contrast CT. Now we have to see the shape of the acute bleed in order to decide where it is located. So look at the first three images here. You can see that there is a crescent or a banana, whatever it is. So there is a crescent shaped hematoma. Here you will have history of some sort of trivial trauma, like an alcoholic who's taken a fall. There is old person who's fallen in the bathroom. So basically some sort of trivial trauma shall be mentioned, because this is acute subdural hemorrhage. Remember, SVH, subdural hemorrhage, is a venous injury. It's a bridging vein injury because of trivial trauma. Now, can it cross the midline? It cannot cross the midline, but it can definitely cross the sutures. That is why it has this shape where it can cross. This is where the sutures are located. It can very well cross the sutures, but it cannot cross the midline. Yeah. On the other hand, is this patient who has a history of a road traffic accident. What sort of a hematoma do we see? We see a lens-shaped, biconvex, whatever you want to call it, idly. So idly will help you remember EDH. So this idly-shaped hemorrhage is acute EDH, extradural hematoma. This is because of an arterial injury. You will usually have a severe road traffic accident here. This is because of an arterial bleed, and the most common arterial bleed here is the middle meningeal artery. It's the anterior division of the middle meningeal artery, which actually tends to bleed here. Does it cross the sutures? No. The fact that it is idly-shaped or lens-shaped is because it is limited by the sutures, but it may cross the midline. So remember either one of them and then just invert it for EDH. Okay. Now this is not it. If you look at the CT scan carefully, you can also see there is one more white lesion here. Now this is not an extra-axial bleed. Extra-axial means outside the brain, like subdural, extradural. They are meningeal bleeds, isn't it? This is an intracranial bleed, and when you have such a hematoma, this is what we call as a contusion. So this is a hemorrhagic contusion right here. And is there a relation of them being diagonally opposite? Have you heard of something called as Coop counter Coop? Wherever there is impact of trauma, diagonally opposite to it, the brain is going to be bouncing back, resulting in another injury. So whenever you have EDH, there is always associated, not always, but usually associated Coop counter Coop mechanism. So we must always screen the area diagonally opposite to an EDH very carefully in case there is a small contusion sitting there. Okay, so this is about EDH versus SDH. If you have history of road traffic accident, or this may also be spontaneous, right? So spontaneously, you may have a patient who's coming to you with a very, very severe headache. They may describe it as a thunderclap headache. Thunderclap meaning it increased in severity very, very suddenly. Also been called as worst headache of my life, right? So that is what you will have as a history in cases of spontaneous SAH. So what you see here is a star. Right? These are the basilar cisterns which are having blood. So this is SAH, standing for subarachnoid hemorrhage. So overall, the most common cause of SAH is indeed trauma. That is more common than aneurysmal rupture. The most common cause of spontaneous SAH obviously is aneurysmal bleed, but overall trauma is more common. The most common site of these aneurysms are called as perianeurysms or saccular aneurysms. The most common site is at the junction of ACA, ACOM, anterior cerebral artery, anterior communicating artery junction. So anterior circle of Willis is the most common site where these aneurysms tend to form. When they rupture, they lead to subarachnoid hemorrhage. A syndrome with which these are associated is polycystic kidney disease, which is a condition associated with these very aneurysms. So you may get a question related to and linking both of these findings. Apart from that, once you have an aneurysm, now how do we treat it? So the preferred method nowadays is a coiling. So intravascular, endovascular coiling is what we do as interventional radiologists. You go in with a catheter and you put coils inside the aneurysm. So that is what is the preferred method of curing or treating these aneurysms. If you have a history of road traffic accident, they mentioned that the patient's GCS is very low. There was a very severe accident that happened, but the NCCT is normal. So they're saying that the NCCT is normal. With such a low GCS and a severe injury, we're expecting a lot of bleeds. Or they mentioned that there are tiny bleeds, particle hemorrhages. This is a classic clinical scenario describing DAI. DAI stands for diffuse axonal injury. So this is DAI, where what you're going to have are these small bleeds called as microbleeds. As the name suggests, this is not a vascular injury. This is where the axons are getting torn. This is because of a shear stress. There is shearing or pulling of the axons, which results in these small bleeds at the sites of trauma. So that is where CT actually will miss or underplay the diagnosis, and that's why MRI is the most sensitive. And the sequence we have already talked about is SWI, susceptibility weighted imaging, where you see wherever the axon is broken, there are these tiny foci of blooming, these black dots, which suggest micro bleeds. So that's diffuse axonal injury. Few more images related to trauma. So now when I show you this image, what do you think is the diagnosis? So we can see that there is a banana-shaped hematoma. So this is subdural hemorrhage, but then what is different? The difference is this is not hyperdense. The SDH we had seen had to be hyperdense to be called as acute SDH. So then what does this become? Yes, this is a repeat question. This is chronic subdural hematoma, and you can see that there is a lot of mass effect. Can you appreciate how the brain is going to the other side? And this is what is called as a midline shift. So whenever you have a significant midline shift as such, this is what becomes an indication to operate. This is an indication of decompression, wherein you need to remove a part of the skull bone in order to decompress the brain. Another indication of decompression is the sign here. First of all, is this EDH or SDH? So you can see that it is limited by the suture. It is not able to cross the sutures. So this indeed is EDH, but now look at the density. In the density, you can appreciate that there are both hypo as well as hyperdense areas. This is what we call as swirl sign. So swirl sign, when you have both hypodense plus hyperdense areas within a hematoma, and this is what indicates that there is actually active bleed which is going on, suggesting a poorer prognosis and an indication of decompression. So this is the swirl sign. What you can see here, you can see that the frontal lobes are peaking, right? First of all, you can see there is black air in the brain and the frontal lobes are peaking like a mountain. This is the Mount Fuji sign. This Mount Fuji sign indicates air within the brain, and this is pneumocephalus. So not air within the brain, but air within the intracranial system. So what you can see here is outside the brain in the extraneural space, there is air. How did this air come inside the cranial cavity? Either there is some sinus, like frontal sinus, mastoid air cells, which are involved by a fracture, or there is an open fracture through which air is coming inside. So these are the two possibilities. And this is not just a pneumocephalus, this is a tension pneumocephalus, because you can see the frontal lobes peaking here. So Mount Fuji sign, tension pneumocephalus. So this is what you need to know from head trauma. One of these always gets asked. Now look at this CT. When I look at this CT, again I can see a hyperdensity here, so I know it's an acute hemorrhage. But where is this acute hemorrhage? So now we know our basal ganglia anatomy, and from that you can tell me that it's involving the lentiform nucleus. So this is a bleed in the outer part of the lentiform, causing basically involving the putamen. So this is a basal ganglia bleed. Some people call it as gangliocapsular bleed, because from the basal ganglia it extends into internal capsule. And the moment internal capsule is involved, particularly the posterior limb, you know all of the corticospinal tracts are arranged in the posterior limb of internal capsule. You have the entire body. We have learned it in BTR fatal. This is the arrangement of the internal capsule corticospinal tracts here. So face, arm, thorax, and limbs. This is how all the body is in this much small area of the posterior limb of internal capsule. So the moment this gets involved by the bleed, you're going to have hemiplegia. So this is what is called as dense hemiplegia. That is how these patients present. And the most common site is putamen here, and this tends to affect patients who have hypertension. So the most common site of hypertensive bleed is the putamen, and the vessel is called as the Charcot's artery. The Charcot's artery is a branch of MCA. It is the lenticulostriate branch of MCA that supplies this part of the brain, and that can rupture here. So what happens is this artery has these small Charcot-Bouchard aneurysms. So Charcot artery, Charcot aneurysm. So these are microaneurysms which form, and they tend to rupture if there is a spike in the hypertension. So that is what is very, very important for putaminal bleed. If I show you this particular CT and I ask you, is this hemorrhagic stroke or is this ischemic stroke? Clearly it's not hemorrhage, right? So when you see this hypodensity here, this is what is an ischemic stroke. Now, ischemic stroke, they will ask you what is the vascular territory involved here. So this largest territory here is indeed the MCA territory. You know, MCA, middle cerebral artery, is the most common artery to be affected in an ischemic stroke. The anterior part here is the ACA territory. The posterior part here is the PCA territory. So this is an MCA territory ischemic stroke. On the other hand, what is this now? So this is also an ischemic stroke, now involving the gangliocapsular location again. But this is a very small volume stroke. So such a small volume stroke, definition-wise, any stroke less than 15 mm in diameter, particularly involving the basal ganglia, is called as lacunar stroke. This lacunar stroke affects the same. Remember the Charcot's artery? So your lenticulostriate branches, your lenticulostriate branches of the MCA, now instead of bleeding, what they're going to do is they're going to get blocked. That is what is called as lipohyalinosis. So lipohyalinosis is what happens. These arteries become narrow and they develop the small volume stroke of the basal ganglia called as lacunar stroke. So this is what we need to know about these images related to stroke. Now talking about brain tumors, I'm going to show you 6 tumors, 3 in adults, 3 in children. You need to know the pattern approach in order to distinguish them. So look at the first one. This is the most common benign brain tumor in adults. What is the feature? The hallmark of this lesion, it's a very vascular tumor which has this tail. So you can see that there is a tail which is involving the dura. So dural thickening with a dural tail sign. This is what is diagnostic of a meningioma. So this is a meningioma dural tail sign. This one here is the most common malignant tumor of adults. It's a WHO grade 4 tumor, the most aggressive tumor. You can see how necrotic it is. The periphery is enhancing, center is not enhancing, and the classical feature is it is crossing the midline. There are very few things which can destroy the corpus callosum and go to the other side, and this is one of them. So this is what, because of its midline crossing ability, is been referred to as a butterfly glioma, and the diagnosis becomes GBM, glioblastoma multiforme, now called as glioblastoma. Okay, so this is the most common malignant tumor. The next one, the location is the hallmark. You can see this is the pons and these are the cerebellar hemispheres. So this is located at the CP angle. So this is the most common CP angle tumor. CP angle meaning cerebellopontine angle. Here you can see this classic appearance of an ice cream cone. So this is the ice cream cone appearance, and what is the diagnosis? This is vestibular schwannoma. So this tumor arises from the vestibular nerve in the internal auditory canal, where it tapers, and then at the CP angle cistern, it expands, giving rise to this classical ice cream cone appearance. Which syndrome will you rule out when you see bilateral vestibular schwannoma, or even a single one? This is associated with NF2, right? So neurofibromatosis 2, where the hallmark is vestibular schwannoma. Moving on to tumors in children now. So this one here is the most common benign tumor in children. It is located most commonly in the cerebellum, and this pattern here is a cyst with an enhancing neural nodule. So this tumor is a cystic lesion with an enhancing neural nodule. And what is the diagnosis? So the diagnosis becomes pilocytic astrocytoma. So this is a WHO grade 1 tumor, most common benign lesion, pilocytic astrocytoma. The next image, where is the tumor? We have already seen the normal anatomy. You can see that the diamond-shaped fourth ventricle is now replaced by this tumor here. So this is the most common malignant brain tumor in a child. This occupies the fourth ventricle, and this is medulloblastoma. So medulloblastoma is in the fourth ventricle. It's a very aggressive tumor, and because of its location, this has access to the spinal canal. So what happens is the tumor drops, right? The tumor drops down and can coat the entire spinal cord, and that is what we call as drop metastasis. So this can lead to drop metastasis, and very important, because of its high propensity to cause spinal metastasis, brain metastasis, this is one of the indications of giving prophylactic craniospinal irradiation. So one additional point for all of you, prophylactic, meaning even though there are no metastases yet, there are few tumors which have such high propensity to cause brain and spinal cord metastasis that upon diagnosis itself, you're going to give prophylactic craniospinal irradiation. What are those tumors? So the first example is medulloblastoma that we have seen. The second example is small cell CA lung. Small cell CA lung tends to have high propensity of invasion. It's a very, very aggressive tumor with most common aggressive hematogenous metastasis. And we have ALL. ALL also tends to have craniospinal metastasis. So actually everything is there in the word small. If you just remember small, you are sorted. So one is small cell CA lung, M for medulloblastoma, ALL for ALL. Yeah. So if you remember small, everything is done here. Third one, and the most important one, perhaps most commonly asked lesion, whenever you see a child, so first see here is a child with a supracellular lesion above the cella, which is calcified. It's actually cystic. It is filled with this keratin here that we describe as wet keratin. It has been described as machine oil on gross specimen. So cystic lesion with calcification, because it is supracellular, this can compress the optic chiasma, leading to bitemporal hemianopia. So all C's together, the diagnosis is craniopharyngioma. So whenever you see the C, all of it goes together. Right? So these are 6 tumors that we need to remember in total, 3 in adults, 3 in children. 4 patterns we need to understand as far as infections are concerned. So look at the first MRI, what do we see? Before I go into that, what did we understand as a concept? That whenever we have infection, tumor, inflammation, what will be my investigation of choice? It will always be MRI, and we shall always give contrast. So it is contrast enhanced MRI, whether it is tumor or it is infection, right? So I assume you will not have to memorize these things. These have well been understood as we have done the thumb rules earlier, right? So I've given contrast, and look at the first MRI here. You can see that there is a lesion which shows me enhancement in the periphery. So what is this ring enhancing lesion? So whenever you see such a ring enhancing lesion, this is what is a cerebral abscess. So this is a brain abscess. If we do a diffusion weighted imaging, we remember this can show us diffusion restriction because of the pus in the central part. This will show restricted diffusion. So this is a ring enhancing lesion, which is an abscess. What part of the brain? So you know these are the frontal lobes, these are occipital lobes. This is a temporal abscess here. All right. So this is how an abscess appears. It's a big ring enhancing lesion. If you have small ring enhancing lesions, now there are 2 considerations. One is NCC. NCC meaning neurocystic sarcosis, and the second consideration is TB. So what I'm about to teach you is how to distinguish these lesions. This image here is a T2 weighted MRI. We can see these multifocal lesions. It may be single also, it may be multifocal also. So don't always look for multiple. That's one mistake I've seen students do, is if it's a single cystic sulcus lesion, they will not make the diagnosis. They'll be like, no ma'am, but we are on starry sky. But you'll not always see a starry sky appear. It can be a single lesion as well. So what you have to understand is starry sky here, then it's good. But if it's not there, doesn't mean you rule out the diagnosis of NCC. Yeah. So what is the hallmark is that there is going to be a lesion which is cystic, and this dot here is the hallmark which represents the central scolex. So when you have either a T2 weighted image or they give contrast enhanced image with a central eccentric dot, that is a scolex, and that represents the diagnosis of neurocystic sarcosis. This is caused by Taenia solium. You know the intermediate host is pig, but this is not necessarily because of eating pork. This can also be consumed with unwashed vegetables. So actually the eggs of the Taenia solium come with the vegetables. So if you are eating, unhygienic vegetable salads, momos, those are the usual carriers of neurocystic sarcosis. On the other hand, in tuberculomas, you can see these multiple ring enhancing lesions again. A property that you see here is that these lesions are conglomerating, meaning they are merging into one another. That's the first point. The second point, which is an old repeat AIMS question, is if you do MR spectroscopy, you're going to see a lipid lactate peak. This just indicates the presence of necrosis basically. So these are your 2 or 3 differentiators. Scolex means NCC, conglomerating or lipid lactate peak means tuberculosis, right? The fourth infection, where the buzzword is now going to be HIV/AIDS. So if I tell you there is a patient who is HIV/AIDS positive, and again I'm seeing these target shaped lesions, you can see there is ring enhancement with a central target, but this is not like NCC. This is involving the basal ganglia. Plus HIV/AIDS will always be mentioned. This is toxoplasmosis. It's the most common infection in HIV/AIDS. So toxoplasmosis, you're going to make a diagnosis with HIV/AIDS in the history, right? So these are the 4 patterns of infection.